So good morning, everybody. This is the third cardiometabolic update of 2025. Medical science is a rapidly advancing field where yesterday's fact may become matter for the archives to store, and today's fact may not find agreement with experts of tomorrow. Continuing medical education is therefore an integral part of medical profession, and I'm sure the proceedings of the webinar will immensely contribute towards better patient care. The first session is by none but Dr. Navin C Nanda, father of echocardiography. His heart and soul, everything resides in him. And he will be talking to us on a very interesting topic from the United States, that is Epicardial Adipose Tissue, clinical biomarker of cardiometabolic risk. Dr. Nanda, please.
This is Dr. Navin Nanda from the University of Alabama at Birmingham. It's a great pleasure and honor for me to be invited to this very prestigious cardio-metabolic update conference organized by none other than Dr. Prof Manoria. Well, when it comes to epicardial adipose tissue and its relationship to cardiometabolic risk, first of all, what is epicardial fat? It is located between the myocardium and visceral pericardium. Epicardial fat by echo is distinguished from pericardial adipose tissue, which is really between the parietal and visceral pericardium. And also it is distinguished from paracardiac adipose tissue, which is located outside the parietal pericardium. Most importantly, epicardial fat is in direct contact with myocardium and epicardial coronary arteries and is perfused through same vascular network as myocardium, positioning it as a key player in cardiometabolic regulation. Epicardial fat protects the heart by providing energy to the myocardium, thermal insulation, mechanical cushioning, and also secreting cardioprotective adipokines. However, in some metabolic states, epicardial fat undergoes pathological remodeling and releases harmful pro-inflammatory and pro-fibrotic cytokines. Hence, it can serve as a clinical biomarker of cardiometabolic risk. Various non-invasive techniques have been used to assess it. One is two-dimensional echocardiography, which is actually widely available, low cost, easy access, rapid applicability, good reproducibility, and radiation-free. The limitation is it's operator dependent and does not provide epicardial fat volume. However, in the future, one may be using three-dimensional transthoracic echocardiography to assess epicardial fat volume. The other techniques, CT and magnetic resonance imaging, are very good. They give a high resolution, good reproducibility by CT. However, they're expensive and time-consuming, and one must remember that there is always a slight risk of cancer with radiation exposure from CT scanning. Well, what is the normal value of epicardial fat thickness by two-dimensional echocardiography? In general, looking at various studies, 7 millimeters appears to be a good cutoff point. So any maximum epicardial thickness measurement of more than 7 millimeters would be considered normal. And actually, it has a very high inter-observer and inter-observer reproducibility and reliability. Here is a illustration to show this parasternal long X-view, which we use to measure the epicardial fat. And we have the left ventricle here, right ventricle, and then this is the right ventricular wall. So this is the right ventricular myocardium, which is in direct contact with this epicardial fat pad, and one can measure the maximum thickness, usually in end systole, and also you can take an average or maximum from 3 or 4 cardiac cycles. And then, of course, on the top, we have pericardial fat here. This particular case mentioned as PF here. right here, PF, and then we have the chest wall there. So very easy to differentiate epicardial fat pad from pericardial fat as well as from the right ventricle. And I wanted to just show you this movie here. And here again in the movie, we can see very clearly the epicardial fat, pericardial fat, chest wall, and here this is a parasternal long axis view with the aorta and left ventricle, and on top of that is the right ventricle. One should also do that not only in the parasternal long axis view, but also in the parasternal short axis view. And in the parasternal short axis view, you have the left ventricle here, right ventricle, this right ventricular outer wall, myocardium of the right ventricle, and then this is a visceral pericardium. So again, one can measure the maximum thickness of the epicardial fat pad. On top of that is the pericardial fat, and then we have the chest wall. And one can also show that in a movie here, very clearly we can see that left ventricle, right ventricle, epicardial fat, pericardial fat, and chest wall here. This is another patient where we have the parasternal long axis view. You have the left ventricle, aorta, right ventricle myocardium here. And again, this is the epicardial fat pad. On top of that, between the visceral pericardium and parietal pericardium is pericardial fat pad. And on top of that, again, you have the pericardial fat shown by this little arrow here. Pericardiac fat. So pericardiac fat, pericardial fat, visceral fat can all be differentiated. And on the top chest wall can all be differentiated in the parasternal long axis view in patients. So here again to show the movie showing the epicardial fat pad, pericardial fat pad between the visceral and parietal pericardium, and then we have the pericardiac fat outside the parietal pericardium, and then the chest wall. Well, one of the important things about epicardial fat by 2D echo is that it correlates much more with the visceral adiposity than general obesity. It's a direct measurement of visceral fat compared to the waist circumference, which includes muscle and skin layers. And as you know, visceral fat is much more is important, very important factor, atherosclerotic factor. So this epicardial fat correlates with metabolic syndrome, insulin resistance, coronary disease, and subclinical atherosclerosis, and may be used for cardiometabolic risk prediction, and also decrease in epicardial fat thickness after weight loss strategies shows its utility in assessing the benefit of these newer weight loss drugs such as semaglutide and tirzepatide. So that's the importance of epicardial fat pad. Now, what are the general applications of epicardial fat assessment by the various non-invasive techniques? Most important is to look at the coronary artery disease. Increased epicardial fat thickness by any of the techniques to two-dimensional or CT predicts obstructive coronary artery disease, which can be useful in primary or secondary prevention. So that's one way to think whether the patient has coronary artery disease, obstructive coronary disease, is to look at this epicardial fat thickness, which can be done routinely in an echocardiogram by looking at parasternal long and short axis views. Also, epicardial fat is a stronger independent predictor of acute coronary syndrome, stronger predictor than traditional risk factors, and can act as a biomarker for acute coronary syndrome risk assessment. Also, when using CT, shows denser fat, which actually reflects the inflammatory activity of epicardial fat. Aerodynamic analysis by CT has also differentiated unstable angina from non-ST segment elevation myocardial infarction. What is subclinical atherosclerosis and stroke? Well, there is a very strong positive correlation between epicardial fat thickness by two-dimensional echo and carotid intima media thickness. This shows epicardial fat's role as a surrogate marker of early subclinical atherosclerosis. There is a meta-analysis using many studies done in 2021, which demonstrated a significant association between increased epicardial fat pad using all the three techniques and stroke risk, independent of traditional cardiovascular risk factors, suggesting that epicardial fat may serve as a marker to identify individuals at higher risk of stroke. How about hypertension? Well, by two-dimensional echocardiography, apical fat thickness in hypertensive patients is increased. Not only that, it is even higher in uncontrolled hypertension. And hypertensive patients with left ventricular hypertrophy exhibit significantly higher epicardial fat volumes compared to those who have no left ventricular hypertrophy. This shows epicardial fat's role as both a marker as well as a potential therapeutic target in the progression of hypertensive cardiovascular disease. Also, increased epicardial fat volume have been shown to relate to myocardial fibrosis and state abnormalities by MRI and in hypertensive patients, suggesting that epicardial fat promotes diffuse fibrosis and dysfunction in the heart muscle. Well, what about diabetes mellitus? Epicardial fat has emerged as a metabolic instigator in the evaluation of diabetes by promoting insulin resistance, chronic inflammation, and myocardial dysfunction. And it has been demonstrated that you have greater epicardial fat thickness in diabetics compared to non-diabetics. And also, I think just like I mentioned before, glucagon-like peptide 1 agonists such as semaglutide have been shown to reduce epicardial fat thickness measured by CT and modulates in pro-inflammatory adipogenesis induction in diabetic patients. So these findings underscore epicardial fat's potential as both a marker and mediator of cardiometabolic risk in diabetic patients. That's important. What about left ventricular diastolic dysfunction? Well, it has been noted that as epicardial fat volume increases, left ventricular diastolic dysfunction decreases. So this relationship between left ventricular and diastolic dysfunction and epicardial fat may be helpful in risk stratification. Now, what about the heart failure to preserve ejection fraction obese phenotype? That particular phenotype in HFpEF, it has been shown that epicardial fat thickness is associated with higher body mass index, and it also shows, as these findings indicate, the potential of targeting epicardial fat in developing personalized therapies for HFpEF. It may be helpful there, and therefore epicardial fat serves as both a driver and potential biomarker of the obese HFpEF phenotype. So it has some importance in obese phenotype HFpEF. It correlates with increased body mass index. So that's very important and for HF. Now, what about low atrial fibrillation? There is a study published in 2011 shows that epicardial fat volume is increased in atrial fibrillation patients undergoing radiofrequency ablation compared to those age and gender matched controls undergoing CT screening for coronary artery disease patients and undergoing CT screening for coronary artery disease with no history of atrial fibrillation. Very important, not only it correlates with the increase with the atrial fibrillation, but also the total epicardial fat volume is associated with recurrence of atrial fibrillation after catheter ablation. So one can get some idea of whether there will be recurrence of atrial fibrillation once you actually look at epicardial fat assessment. There's also another study showing that patients with higher epicardial fat volume on CT showed signs of reduced left atrial ejection fraction and lower left atrial reservoir strain during exercise, indicating compromised atrial compliance under stress. These findings highlight that excess epicardial fat may be a potential biomarker for impaired LA function and reduced exercise capacity, offering valuable insight for risk stratification in atrial fibrillation patients. Well, what about obstructive sleep apnea? As you know, obstructive sleep apnea is increasingly recognized as a key cardiometabolic risk factor due to the recurrent episodes of hypoxia, sympathetic activation, and systemic inflammation that accelerate vascular dysfunction. And what has been shown is that apical fat thickness rises in tandem with obstructive sleep apnea severity. The greater the epicardial fat thickness, the more severe is obstructive sleep apnea. So these actually findings highlight a potential link between epicardial fat accumulation and the progression of obstructive sleep apnea, supporting its role as a useful indicator of disease burden. Well, what about aortic stenosis? Epicardial fat accumulation may trigger or intensify inflammation, oxidative stress, and aortic valve calcification, hastening valvular degeneration. And it has been shown that epicardial fat thickness by two-dimensional echo demonstrates, is associated with severe aortic stenosis. So the larger the apical fat thickness, the more severe would be the aortic stenosis. Also, larger apical fat thickness on CT is found associated with the development of symptoms in asymptomatic patients with aortic stenosis. So it actually gives you an idea that the larger fat pad would increase the chances of patients developing symptoms in those who are asymptomatic patients with aortic stenosis. Now, also, there's another study which was done just last year. It shows in patients who are undergoing TAVR, transcutaneous aortic valve replacement, using epicardial fat pad using CT, found that those with higher epicardial fat volumes experienced increased rates of major adverse cardiovascular events over a median follow-up of about 2 years. So therefore, epicardial fat is not only a contributor in aortic stenosis progression, but also serves as a valuable biomarker for post-TAVR risk stratification. What about the kidney function? The recent conceptualization of cardiovascular kidney metabolic syndrome underscores really the interconnectedness of the heart and kidney as they become affected by metabolic risk factors. One of the investigators have noted a negative correlation between glomerular filtration rate, GFR, and epicardial fat volume by CT in patients undergoing CT for evaluation of coronary artery disease. So there also you have increased actually epicardial fat thickness in patients with microalbuminuria as compared to those who have no albuminuria, suggesting the potential utility of epicardial fat in predicting kidney damage also. Pulmonary hypertension. In a retrospective study, greater initial epicardial fat volume and greater increase of epicardial fat volume between initial and follow-up CT scans were both associated with worse survival in patients with pulmonary arterial hypertension. In another study using cardiac MRI, epicardial fat volume was associated with right-sided heart failure in pulmonary hypertension patients. This actually suggests that this suggests the role of epicardial fat in categorizing pulmonary arterial hypertension disease severity. So epicardial fat volume is also useful in patients with pulmonary arterial hypertension, has value, kidney damage, obstructive sleep apnea, and many other conditions that I mentioned. Well, there are still several changes and limitations, challenges and limitations to epicardial fat assessment. One is unclear causality. Although elevated epicardial fat is strongly associated with many cardiometabolic risk factors, the precise role it plays, whether it is a contributor to disease or it's a prognostic biomarker, still remains debatable. And also there are imaging limitations. We know that echo is widely accessible, used a lot, but at the same time does not actually predict volume, does not actually provide volume. On the other hand, cardiac MRI and CT offer more accurate volumetric assessment, but are costlier and less widely available. There is also one other thing. There's a lack of standardized cutoffs. We do not know whether there are variations in relation to age of epicardial fat thickness, in relation to age, sex, and ethnicity. Especially, we don't know whether we can use 7 millimeters in Asian Indian patients as compared to the other ethnic groups. Other ethnic groups is 7 millimeters. The Koreans have also shown something like 7 millimeters, but we do not know whether that number would apply to Asian India. So there are quite a few limitations and challenges. Also, there are some studies which show no relationship. There are some studies showing no relationship with epicardial fat pad, and some of the things I've mentioned, some of the conditions I've mentioned, but most of the studies agree with what I've mentioned earlier. In conclusion, assessment of epicardial fat by two-dimensional transthoracic echocardiography is an inexpensive, reproducible, and direct measure of visceral fat, may have an important role in predicting and stratifying cardiovascular risk in the clinical settings. However, very important, however, more robust and convincing evidence is still necessary to evaluate whether echo-EF and echo-epicardial fat, and maybe using even other techniques, may have these diagnostic and predicting properties. So future studies are definitely warranted, but it's very important. I think something we can easily look at by echocardiogram, by looking at quite long and short axis view, can check and see whether there's increased apical fat pad or not, and can give us some sort of a hints whether the patient has, for example, obstructive coronary disease and correlates with many other abnormalities. Thank you very much for your kind attention.
Sir, can I ask a question?
Thank you, Professor Nanda, on an excellent disposition. It is for no reason that you are a pioneer in echocardiography. Today, you have beautifully illustrated the role of epicardial fat. I am aware there are many who know EF only as ejection fraction, but you have thrown an additional light on what the multiple benefits and advantages of performing a 2D echo for the purpose of epicardial fat. Particularly interesting was that you said it can be an instigator, and therefore you have highlighted all the things that can happen in metabolic syndrome, particularly some valvular lesions, hypertension, diabetes mellitus, atrial fibrillation. The range is indeed wide. We are grateful to you for this excellent lecture. I am happy to add here that Professor Nanda has been an alumnus of King Edward Memorial Hospital, right now celebrating its centenary celebrations. And I have the fortune of having led and directed this institution. Thank you once again, Professor Nanda.
Dr. Nanda, epicardial fat has multiple utility as pointed out, but is not widely used by many echocardiographers. What is the reason for this? Hello?
Sir, could I ask one question also?
Just a minute. Dr. Nanda?
Yeah.
Epicardial fat, as you pointed out, has wide utility, but is not commonly used by echocardiographers. What is the reason behind it? Sir, you are mute. Dr. Nanda, you are mute. Dr. Nanda, you are mute.
Can you hear me now? Can you hear me now?
Yes.
Yeah. I think most of the echocardiographers are not really aware that epicardial fat is so important. And I think there is a need to make them aware of this, especially if one realizes that epicardial fat pad is in direct contact with the myocardium. So that's why it has a very important influence on the myocardium. People are not really very much aware of this. And also, as you know, in the literature, it's still not very much established what is the normal upper limit value. But we now know it's about 7 millimeters or so. So I think it's very important when you do an echocardiogram, just take a quick look at the epicardial fat pad on the top, and just see if it's large or small. And if it appears to be large, then you know it may have some a lot of significant implications.
Sir, could this be one of the important mechanisms by which GLP-1 and other anti-obesity drugs?
Yeah, I think that's what I emphasized actually twice actually in my talk, that this may be something very important to look for as patients lose weight or they're on these drugs, on these medications at that time. Yeah, right. And it may be very important to look at the epicardial fat in those patients just to get an idea of the follow-up as what's happening with the visceral fat, you know, since it
One
epicardial
question.
fat pad. Yeah. Yes.
Yeah, Dr. Vinod Vijan. So if we are in a multicenter trial with semaglutide with Novo Nordisk, and one of the prerequisites we were told is to measure epicardial fat, and even the technicians didn't know what it means. And believe me, some time back, even we were wondering which is the one to be measured. And of course, it is very clear. We had gone through literature, but reporting of pericardial fat in all the semaglutide trials is mandatory. Whenever we do the test, we ask them, what are the limits? We have no idea. They said, no, you just measure and send it to us. And we will measure ourselves or get food echoes. So it is already there in offense.
That's very good. And also, it's very important to mention that you make sure you are looking at epicardial fat pad and not kind of combining it with the pericardial fat or actually also the paracardiac fat. So you really have to be very careful to make sure that you're measuring the correct number there, or the correct topic that makes. You really have to differentiate very carefully the three types of fat which surrounding the heart.
Dr.
They
Nanda,
tell us to do in the Zoom mode along the RV.
Yeah, you can do it by Zoom so long as you get the peripheral long axis view. You can. I saw some of the movies that I showed, and it's not something you have to specially do it. I mean, even if you do routine echo, making sure you get enlarged images and make sure you don't obliterate the chest wall. Sometimes people do that, don't obliterate the chest wall. Then it's very easy to check for this epicardial fat. And then do it in long and short axis view, two views, and you go to the maximum from the two views.
Dr. Nanda, there are reports of myocardial fat deposition, so-called myocardial steatosis. Any comment on this besides epicardial, pericardial, and pericardial fat? So
I think that it also relates with that. I think I had that on the slide, but I didn't, because of the time limitation, didn't go very much into that. But I think it does. Myocardial steatosis is also something very important. As a matter of fact, if you look at liver steatosis also, it relates quite well with the epicardial fat pad, so that we are looking at just not only the fat in the abdominal cavity and the also abdominal organs such as liver.
is it that epicardial fat is always associated with pericardic fat, or you can have epicardial fat separately?
No, I think I don't think everyone has studied other types of fat. The only thing one is thinking is that because epicardial fat pad is in direct contact with the myocardium, the other fat which is actually the fat pericardial, and they are not really in contact with the myocardium. Now, one other thing that echo may not be able to do very well is to look fat in the atrioventricular grooves or the interventricular sulcus, which has also been shown to be important. But we are only looking at the fat in front of the right ventricle. But this has shown to be quite useful, as I showed in many of the studies. But CT and other MRI may show more fat in some other areas. For example, in atrial fibrillation, one can see the fat pad around the left atrial appendage also. That's increased when you have in patients with atrial fibrillation. So those can be done, but then obviously those are more expensive techniques. But just looking at apical fat pad by echo itself is very important.
Any data from 3D echocardiography on epicardial fat?
No, none. It's very interesting. There's no real data at all from 3D echocardiography. So that's completely new avenue to check for the volume of epicardial fat pad. One of the other reasons why I think if people have ignored apical fat pad is because it's so very close to the chest wall that you really forget to look at it, or your attention is all riveted or mainly concentrated on the other features like the right ventricle, left aortic valve, etc. So you really don't pay that much attention to the epicardial fat pad.
So thank you, Dr. Nanda, for a very informative and a very exciting session. And I'm sure in future, echocardiographers would be utilizing measurement of epicardial fat, pericardial fat, and pericardic fat in their day-to-day practice. Thank you very much, Dr. Nanda.
Okay, thank you, sir. Thank you.